When we talk about patients with status epilepticus, there's going to be a subset of patients that have history of epilepsy. But the majority of the patients that we encounter day to day are patients that they have not had epilepsy history, but rather has had an acute brain injury that is either structural or non-structural, as for example, meningitis or encephalitis or toxic metabolic. We cannot, unfortunately, go back in time and save those unaided brains. But as soon as we have these patients in our ICUs or in our hospitals, we can try to prevent any further secondary brain injuries. We know that electrographic seizures can cause metabolic crisis in patients that have had brain injury. We have good data, but looking at the likely to period ratio, by looking at the cerebral oxygenation, that when seizures occur, there is a metabolic crisis that is going to be affecting the unaided brain. So in order to prevent the secondary brain injury in these patients, what we need to do is the diagnosis of the seizures early on, to have early on intervention so we can prevent secondary brain injury. One of the things of interventions that we can do is try to get a better neuromonitoring that can be early on detecting these electrographic seizures. A Scalp EEG is a beautiful tool that we normally use and has become a standard of care in our hospitals. However, a Scalp EEG has its own limitations. And we know that a lot of the seizures, or some seizures, let's just put some seizures, and we know that some seizures are not detected on a Scalp EEG, but rather are solely detected on depth electrodes or depth EEGs. We don't have guidelines to recommend us who is the best patient that will benefit from these depth EEGs. We don't have guidelines to tell us where to put it. It's in the left frontal lobe, right frontal lobe, temporal, parietal. I guess impossible to put a temporal, so just right frontal, left frontal lobe. So we need further guidelines and studies to see if depth electrodes, will be able to indeed capture these early seizures that we can act upon and where to put them. Now, something else to think and to discuss is that in status epilepticus and in seizures, there's going to be also a neuroinflammatory cascade and a neuroinflammatory response. And we have, by the epilepsy evidence, we know that also neuroinflammation can perpetuate neuronal circuitry hyperexcitability, that it will predispose the patient to have seizures. But we don't have biomarkers to tell us which patients are having a neuroinflammatory response, and we don't have interventions about if these patients will benefit for any immunomodulators as a prevention of the neuroinflammatory response that has occurred either after the brain injury or after a seizures that have occurred in these unaided brains. So we need more research into these two types of realms. There are some ongoing trials that have recognized that neuroinflammation can happen after acute brain injury as well after seizures or electrographic seizures, and this neuroinflammation can perpetuate brain damage or create more brain damage, as for example in patients that have suffered traumatic brain injury and intracerebral hemorrhage. And some interventions such as Anankita has been studied currently. So we're hopeful to see some of the results and see if this can benefit our patients.